Dear faculty members, colleagues, and students, Assalamu alaikum and very good evening and welcome everyone. The incidence of the gastric cancer has decreased substantially in the USA and the Western Europe. However, the gastric cancer still continues a major health problem in the East Asian countries. So the management of the gastric cancer has changed a lot over the decades. The outlook of the gastric cancer is more favorable, more good than it was before. Particularly আমরা যখন ট্রেনিং এ ছিলাম, in our time, it was very gloomy for the captains of Pan's death. However, now outlook is very good with the advent of the newer uh, introduction of the newer adjuvant therapy, other surgical technique, and we know the disease and perhaps more about the biology of the disease. This newer development, energy devices, new chemotherapy, molecular analysis, and to some extent, targeted therapy and the ERAS protocol has changed the outlook of the gastric cancer management. MDT is the key to rectal is gastric cancer management. Today in these sessions, we have a distinguished general surgeons, our guest speaker from Rajiv Gandhi Cancer Institute, Dr. Shivendra Singh, and the medical and the radiation oncologist. I think it would be a very good opportunity for the students to interact with them and to ask questions as much as you can. So feel free to ask any question to them. Here, all are here just to make clear your confusions and the shadow areas in the field of this gastric cancer. I hope you'll enjoy the session and we'll have a very wonderful time with us. Dear students, it's an opportunity for you to participate in the case presentations that will make you more stronger during your exam. So you'll face the encounter the examiner and just enroll your name for the upcoming presentations. I have nothing to disclose. The information that we will provide usually in this webinar is taken from the online journals, NCCN guidelines, and the seminars. No harm to say, I don't know. This day, we don't know many things. Everyday medical science is changing. So we are also learning. So it's no harm to say, I don't know. Just keep an open mind. All the faculty members are here very friendly. Ask as many questions as possible. And today, our topic is the gastric cancer. There will be a discussion chronology. First, there will be polling, followed by case presentation, and followed by faculty presentation. Dr. Shivendra Singh, I will introduce him later on, and followed by a question answer session, comment from the faculty member, and the brief summary and the take-home message of the day. Our esteemed guest speaker of the today's webinar, we have the privilege of welcoming an exceptional foreign faculty member with extensive experience in gastrointestinal and the hepatobiliary oncology, Dr. Shivendra Singh. Dr. Shivendra Singh brings a wealth of knowledge and expertise and accumulated through the years of dedicated practice and research in the GI and the hepatobiliary oncology. He holds an impressive academic background with a specific focus on the GI and hepatobiliary cancer. Dr. Shivendra Singh, you are welcome to our today's webinar. And Dr. Kamaluddin, you are also welcome. And thank you very much for joining us today. And Professor Margoshan sir, thank you very much for inspiring this webinar or to continue this webinar. First, our session will start with the polling. This is basically a pre-test. We want to know or just to gauge the students' basic understanding about the gastric cancer. Will be moderated by Dr. Muhammad Saiful Islam, consultant surgery. I would request Dr. Saiful Islam, please conduct the poll. Dr. Saiful Islam, please come to the screen and conduct the poll.
So our first question was endoscopic examination and forceps biopsy at least 5 to 8 is the gold standard method for diagnosing gastric cancer. The correct answer is yes. So we all know this is very basic. So about 82% student gave correct answer. I don't know why 18% student they are having any confusion regarding this. So our next question was regarding esophagogastric junction tumor, that is GEG. So CWAT type should be determined in all adenocarcinomas. CWAT type 1 is tumor of lower esophagus with epicenter located within 1 centimeter to 5 centimeter above the anatomic esophagogastric junction. CWAT type 2, truly esophagogastric tumor with epicenter within the 1 centimeter above and 2 centimeter below the esophagogastric junction. And type 3, subcardial carcinoma with the tumor epicenter between 2 centimeter to 5 centimeter below esophagogastric junction that infiltrates the lower esophagus. So correct answer is all of the above. Actually, the CWAT classification, it should be mentioned by the endoscopist during an endoscopy, and it has some implications that CWAT type 3, we consider it as a CA stomach, not CA esophagus. So, and the treatment protocol is like carcinoma of the stomach, type 3. And type 1, 2, it is treated as carcinoma of the esophagus. Our next question was MSI or MMR should be performed in all newly diagnosed gastric cancer. Though it is not practiced widely in our country, I don't know whether some centers of India must have included this one in initial diagnosis. But we in our country, we are not still practicing, but it is recommended to do MSI or MMR in a newly diagnosed gastric cancer that determines the whether the chemotherapy will work or not. In a MSI unstable patient, the chemotherapy sometimes it doesn't work. Then we have to think of the immunotherapy or other second line regimes. So that's why it is recommended MSI and MMR should be done in all newly diagnosed gastric cancer like that of colon and rectum. HER2 and PD-L1 should be performed in all cases of gastric cancer. The correct answer is no. It should be performed in locally advanced or metastatic cancer only. We don't have to do HER2 and PD-L1 in all cases of gastric cancer. Itero implication is that if HER2 is positive, then we can give trastuzumab, and PD-L1 is positive, we can add immunotherapy, that is nivolumab and like others. So here 50-50 almost, 59% student gave the wrong answer and 41% student gave correct answer. So our next question was staging laparoscopy and peritoneal lavage cytology are recommended for patient with resectable gastric cancer who are also candidate for perioperative chemotherapy to exclude radiologically and macroscopically occult peritoneal metastatic disease. So in a plain language or সোজা কথায় বলতে গেলে staging laparoscopy and peritoneal lavage cytology is recommended in all cases of gastric cancer, in all cases, মানে except T1. Otherwise we have to do in all cases before starting chemotherapy, even after chemotherapy, before doing any definitive surgery. So number 6, for stage 1B and 2-3 gastric cancer, a proximal margin of more than 3 centimeter is recommended for intestinal histotype and more than 5 centimeter is recommended for poorly cohesive or diffuse type. So about 90% student gave the correct answer. It is recommended in ESMO now that in intestinal type we can have only 3 centimeter, at least 3 centimeter, we can have the proximal margin. Question 7, for stage 1B to 3 tumor, perioperative use of 5-FU, oxaliplatin, and docetaxel is standard for care for patients who are able to tolerate a triplet cytotoxic drug regime. That is the FLOT regime. About 92% student gave the correct answer. That is good. So number 8, another chemotherapy in our subcontinent, that is Asian people, that is the S1 chemotherapy. So we'll not cover that in polling. I think later on Dr. Kamal sir may mention this one later on. S1 chemotherapy. So next question, number 8, standard gastrectomy is the principal surgical procedure performed with curative intent that involves resection of at least 2/3 of stomach with a D2 lymph node dissection. The correct answer is yes. About 90% student gave the correct answer. Correct statement regarding lymph node dissection in distal gastrectomy. D0, lymphadenectomy less than D1. D1 is station 1, 2, 4SB, 4D, 5, 6, 7. D1 is D1 plus, that is D1 plus 8A and 9. Sir, shall I mention the what station indicates which?
I think later on. But
Acha. Okay, sir. Okay. All of the above was the is the correct answer. So in a D2 gastrectomy, we should have all the lymph node dissected. That is stations in lymph nodes in D1 plus 8A, 9, 11P, and 12A. That is the celiac, common hepatic, and splenic artery along these vessels, lymph nodes. So correct answer here is all of the above. Correct statement regarding lymph node dissection in total gastrectomy. Again, D0 lymphadenectomy less than D1. D1 is 1 to 7. D1 plus 8A, 9, 11P, and D2 D1 plus 8A, 9, 11P, 11D, 12A. So এখানে একটাই ডিফারেন্স হচ্ছে
I think
D1.
আমার মনে হয় যে briefly just explained, otherwise we will not understand. Briefly, you can explain what is really mean by this station.
Okay, sir. So, sorry, say it would be better if we can show a image. If we can show a image.
Can you see the image now?
Yes, sir. Yes. So here we can see this is a picture of partial or distal gastrectomy. See the station 1 is the right pericardiac, and on the opposite side is the along the greater curvature, that is the station 2. In distal gastrectomy, we don't have to dissect the station 2, that is in the along the greater curvature, right, that is left pericardiac region. So, and lymph node group 3, that is along lesser curvature, 5 suprapyloric, 6 subpyloric, 4D along the greater curvature, and 4SB. So here these all blue marking lymph nodes, these are all station 1 lymph node, that is D1 dissection. D1 plus, we sometimes along with this lymph node, we dissect only the station 9 or 8A. That is D1 plus, that is along the celiac or 8A. And 12A is along the hepatoduodenal ligament. A means artery, that is along the we all know that is common hepatic artery that arises from the celiac trunk, goes to the right, and it enters into the hepatoduodenal ligament as hepatic artery proper. So 12A is the lymph nodes of hepatoduodenal ligament along the hepatic artery proper, and 12B is the bile duct, along the bile duct. So we don't have to do all the lymph nodes in hepatoduodenal ligament. We only have to do that 12A, that is along the hepatic artery ligament. And 11P is the along the splenic artery. P means proximal. In distal gastrectomy, we do only the proximal one. Sir, please show me the later. That is the, now will be more clear. See, now the number 2 in total gastrectomy, number 2 lymph node station is included, because we'll resect the whole stomach. So the left pericardiac region will include, and the station 2 lymph node will come in the specimen. That is the D1 in total gastrectomy. So the lymph node dissection in D1 and D2 in total gastrectomy, subtotal gastrectomy, it is different. And we have to take the 11D, that is previously we have shown only 11P, that is proximal spleening. But in total gastrectomy, if we want to do a D2 dissection, 11D, that is distal splenic vessel, lymph node should be included.
Thank you. Then
okay, so our next question number 11 is long-term complications of gastric surgery include all except vitamin B12 deficiency, iron deficiency anemia, osteoporosis, dumping syndrome. It's a mixed answer. Maximum student gave 38% gave dumping syndrome. Actually, dumping syndrome, it is early, not long-term complication. Dumping syndrome occurs early and it later on adapts. Other 3 are long-term complication, but dumping is early complication. So last question was, HIPEC is a therapeutic alternative for carefully selected stage 4 patient with limited peritoneal metastasis in the setting of ongoing clinical trials only. This is the line from NCCN. I just take it from there as it is. And the answer was yes. About 95% student gave the correct answer. Thank you, sir.
Thank you. Thank you very much. Even then, question কঠিন হলো স্টুডেন্টরা খারাপ করেনি, ভালোই করেছে।
Yes, sir.
They have done good, and I think from yeah, the presentation of Dr. Shivendra, everything will be cleared. I think
Yes.
it will make it clear. Now I will take a comment from Professor Margubhushan sir. Sir, will you please make comment on these questions today? As the students already the toughest polling forever.
Well, I could say they have gone to be a wise geezer,
Right, sir.
wiser. At least they are thinking on it.
Yes.
It's difficult to follow these numbers, no doubt, and practically identifying them in our setting, that is at the stage 3 or stage 2, it becomes difficult really. Number 1 to 15. Now it has become more separated by different situations. It is difficult, but you can remember them by grouping them in together. And I think it is better to have some names of them. That will be better for the to remember what is that there. So students have done well.
Yes, yes.
They're thinking well because they're thinking well. They're thinking deeply. That is the and we should try to use less of the abbreviations, at least for exam purpose.
Okay, sir. Thank you, sir. Thank you. Now, Dr. Shivendra, please comment on this today's polling.
I think students have done very well. It was said to be toughest, but they have done reasonably well. So they have studied CS stomach, I think.
Okay, okay. Thank you very much. I think you will make it more clear.
I'll try to do whatever.
During your
best I can do.
presentations. Okay, then. Thank you very much.
Yeah.
So now we are switching.
Sir, student to জিজ্ঞেস করতেছে না, I have some query.
Okay.
The first polling, the specimen was 5 to 8. Saiful, please, could you clarify it? Earlier we know minimum 8 or minimum 6.
Sir, it is
something
now
like that.
recommended.
Now
It is, sir. Yes, sir. Sir, in intestinal type, we can take at least 3 centimeters. Sir, এখানে
No. First polling. Specimen endoscopy biopsy.
5 to 8. Yes, sir. Sir, it is written in guideline. 5 to 8 is sufficient.
তাহলে আমরা স্টুডেন্টদের মিনিমাম কত বলবো ওরা পরীক্ষায়? What would be the answer in the exam? But earlier they used to know the minimum 8, right?
Yes, sir.
Hello,
8. I think 8 is. I think 8 is okay.
Dr. Shivendra, will you make any comment on this?
I think initially it was that in the all quadrants, you should take at least 2 biopsies from the all quadrants. If there is some ulcer, all 4 quadrants should take 2 biopsies from each quadrant. It
Yes.
makes 8 biopsies.
Right.
Okay.
It's a
So
good.
minimum 8, right?
Yes. Yes.
Okay, then. Thank you. So now we'll switch over to our next.
আরেকটা হলো কমেন্ট স্যার।
Uh-huh.
The SWOT type, probably some of the students heard this terminology first time, probably what I guess, as they are telling this is a very toughest one. But what we attended in the conference, there was a session only about the SWOT type.
Keyword type.
Yeah, there was a very whole session on the
Yes, sir.
SWOT type. So much discussion on this tumor. As we know, the proximal gastric is much more and more than that of the distal one. So in course of time, our student and now on, they have to know and they have to learn of the SWOT type in details. এটা হলো আমাদের কথা। The other comment is HER2 and MSI-MMR is MSI-MMR we are still doing the colon cancer, especially the colon, not doing the practicing the stomach cancer. But in course of time, the days are not very much far away. We have to adapt with these sorts of investigation for the better management of the patient as a whole. So they are just informed about the KCS stomach, that MSI-MMR HER2. They have to be accustomed with these sorts of investments. Once there will be the one with the specialist after passing the fellowship. Thank you, sir.
Thank you, Professor Masud Karim. Thank you. Now, a case presentation. Case will be presented by Dr. Mujahid. Dr. Mujahid, can you hear me? Please come to the screen, introduce yourself, and present your case, please. Dr. Mujahid. Mujahid, can you hear me?
Assalamualaikum, sir. Am I audible?
Yes, you are audible. Introduce yourself, please, then present your case.
I am Dr. Mujahid, Phase B resident, Chattogram Medical College. Today I'm presenting a long case regarding carcinoma stomach.
Please don't put any marks on the screen, please.
দেখতে পাচ্ছ এখন?
Yes, sir.
Okay.
Mr. X, 45 years old, presented with a complaint of vomiting for last 2 months, which occurs after taking meal. Vomitus is moderate amount, bilious in color, bitter in taste, containing food particles, occurs within few minutes after taking food. He also complains of loss of appetite and significant amount of unintentional weight loss for last 3 months, which is about 10% of his previous body weight. He also complains of anorexia and generalized weakness. His bladder habit is normal, but gave history of constipation. He has no history of hematemesis and melena, gave no history of cough, hemoptysis, jaundice, bone pain, and chest pain. He gave history of open nephrolithotomy 10 years back under general anesthesia, and procedure was uneventful. He was smoker for 20 years and occasional betel nut chewer and non-alcoholic. Patient is immunized as per EPS schedule. No history of blood transfusion. None of his family member has such type of illness. He gave no history of allergy to any food and medication. Patient is anxious looking, cooperative, nutritional status is below average, ECOG score is 0.1, BMI is 17. Patient has mild pallor, not icteric, and no sign of edema and dehydration. All other vitals are within normal limit. All accessible lymph nodes, including left supraclavicular lymph node, are not palpable. There was a linear scar mark on left flank region, which is about 10 centimeter in length, healthy, no sign of incisional hernia. On abdominal examination, shape of abdomen is normal, flanks are not full, umbilicus is centrally placed, inverted, no induration around the umbilicus, no angers vein, no visible peristalsis, hernial orifices are intact. Liver is not palpable, upper border of liver dullness is present in right fifth intercostal space, no other on midclavicular line, no other organomegaly. Bowel sound is normal, TR reveals no abnormality, genital examination is normal, other systemic examination reveals no abnormality. So my clinical diagnosis is carcinoma stomach.
Thank you, Dr. Mujahid, for presenting the case. And now you will face the examiner. Your diagnosis is carcinoma of the stomach. So first I will request Professor Margubhushan, sir, please make comment on his presentation.
How do you diagnose carcinoma stomach in this case? What are the evidences? Mujahid?
You are muted, Mujahid. You are muted.
মুজাহিদ তুমি মিউটেড আছো, মিউটেড।
No, no.
আনমিউট করো, আনমিউট। হয় নাই, এখন আনমিউট করো তুমি। হ্যাঁ,
Yes,
ইয়েস।
sir.
Okay, okay.
Sir, patient has anemia, anorexia, and asthenia, and patient is male patient, age is more than 45 years old, and this is the in favor point of stomach.
Did you feel any lump there? Nothing.
No, sir, there was no lump in
No
the
hematomesis, no melena. Then
No,
why do you
sir.
say this is malignant? Why not is pyloric stenosis, simply pyloric stenosis?
Because patient gave this is a short history, only 4 months, and patient gave history of significant weight loss, which was 10% of his.
Can you
body
say without doing an endoscopy? Can you say this is a carcinoma stomach?
No, sir.
You know
This is my
the weight of this diagnosis.
No, sir. This is my provisional diagnosis. I will confirm it after
So
endoscopy.
why not a benign condition first?
Because this is short history.
With a short history. Can it be some severe gastritis or something like that?
No, sir. In case of severe gastritis, patient may complain of
Why this is not
epigastric pain.
gastritis?
Right.
In case of gastritis, patient will complain of epigastric pain or associated with fever. And
Do you think that in gastritis there is fever?
Fever.
আইটিসে ফিভার থাকবে না তো
the patient will complain epigastric pain.
Complain of gastric pain. Did you take a history of taking antacids and other drugs for that, for his pain, for his condition?
Yes, sir. Patient didn't give any history of taking PPI, proton pump inhibitor, or any anti.
There is no history like that.
Yes, sir.
So for 2 months he's just waiting in their home with losing weight and other things. There is no vomiting, nothing like that.
Yes, sir. There was vomiting, but initially it was small in amount, but
Well, this is diagnosis is for too much for me, I think. So what can you do then?
I will, sir, confirm my diagnosis by doing upper GI endoscopy and possible biopsy.
You think that in every case you will get evidences of cancer stomach after doing this endoscopy?
No, sir.
Where you can fail? You might fail, or the endoscopy might fail.
If
There is
endoscopy,
stomach, but he could not see with the endoscope.
okay, we'll go for barium meal
না না
study.
প্রশ্ন
No.
বুঝো তুমি
Why
প্রশ্নটা বুঝেছো?
endoscopic may miss a diagnosis? You understand?
If scoop couldn't pass the
না না শুনো তুমি বাংলায় বলে আমি স্টোমাকে ক্যান্সার আছে কিন্তু এন্ডোস্কোপিতে দেখা যাচ্ছে না এরকম কোনো সিচুয়েশন আছে কিনা অবভিয়াসলি দেয়ার ইজ এ ক্যান্সার কিন্তু এন্ডোস্কোপিতে বোঝা যাচ্ছে না। এটা
if mucosa is not involved.
For the percent case, in which proportion of cases it is false negative endoscopy?
Sorry, sir.
You know it?
No, sir.
Okay, endoscopy says this is normal. Then what you do?
I will follow up the patient and I will go for
Huh?
colonoscopy. I will do colonoscopy.
Do you think that will give you a good result? There is no ascites.
No, sir. No ascites.
Nothing like that. Huh? So if it is positive, what should be the result? There is the obstruction, or no obstruction. What will you get?
It may be case of partial obstruction or
Partial obstruction. What is that? Partial obstruction? How do you classify that? Partial obstruction or complete obstruction?
if scoop couldn't pass
But the endoscopy
beyond
should say that this is partial obstruction or this is complete obstruction.
if there is luminal narrowing, then it is partial. And if scoop couldn't pass beyond the junction, gastroduodenal junction, then it is complete obstruction.
So if there is no obvious lesion, where from do you take the biopsy?
No, sir.
In the lesion, you take 8 biopsies or 8 samples for that. But if there is no specific lesion, then what do you do? Is there any type of gastric carcinoma where the mucosa looks normal?
Yes, sir.
What is that?
This is gastrointestinal tumor.
Any other thing?
Endophytic type or exophytic type? In the exophytic type, you will not get anything, but in the endophytic type, you get that. But in carcinoma stomach, there is a variety where it looks normal.
Superficial flat variety.
Huh? Okay, thank you.
Okay, thank you, sir. Professor Masud Karim, would you want to ask any question?
Sir, first তো স্যার সব ঝামেলা পাকে ফেলছে। First of all, the diagnosis is straightforward carcinomas you cannot say. Why is there any outlet obstruction?
No, sir, there is no feature of outlet obstruction.
But complaining of vomiting for 4 months? How can you explain that without any obstruction?
Vomiting for 2 months and after taking meals.
You said the first line, vomiting after 4 months after taking meal. Then how can you explain without obstruction?
Sir, if there was obstruction, the food materials would be partly digested or partly undigested food material.
Okay, I understand. But how can you explain without obstruction this vomiting 4 months?
Sometimes carcinoma stomach has gastritis.
Gastritis, vomiting due to gastritis, but food material test is the beta test that reflects it's not an occlusion.
Duodenal content.
Did you found any sort of clinical test on obstruction? Did you test it clinically for obstruction?
No, sir.
What clinical test you can do or you can do?
We can do, sir, succussion splash.
What is that? But how can you, what is the prerequisite of succussion splash?
Sir, we will use normal saline, 200 ml normal saline through NG tube, and then we'll wait for 4 to 5 hours and then do this procedure.
Okay, but can you do without pushing the normal saline? Can you ask anything to the patient? Then you can do the test. What is the transit time for water in the stomach?
50 minutes.
Tell me. You are 50 minutes, but you are waiting after putting the normal saline for 6 hours. Why?
If there is complete obstruction,
normal
then
saline sort of water, right?
Yes, sir.
তুমি ক্লিয়ার করো, জিনিসটা ক্লিয়ার করো। You are putting the normal saline in the stomach through the NG tube and waiting for 4 to 6 hours, then you will see the succussion splash. So then the next question will be, what is the transit time for water in the stomach? কতক্ষণ থাকে water?
15 minutes.
Why? Maximum 40 minutes if there is no obstruction.
Yes,
so
sir.
while you waiting for 4 hours or 5 hours?
If there is obstruction, then water will not passes through small bit.
Can you do the test without putting the water to the stomach, to the rice tube? Can you ask anything to the patient, then you can do the test? Patient will drink once upon a time. We ask the patient, when did you drink last time? You will say,
Yes,
early
sir.
in the morning or 3 hours before or 5 hours before, okay? Then we
Okay,
can
sir.
judge the test, okay?
Okay, sir.
That is a very simple question, okay? So what I see you do have a lot, what I think, a lot of shortage in the knowledge regarding the history accumulation of what the sir asked you. You straightforward cannot say with these sorts of history the carcinoma stomach. Carcinoma stomach is a histological diagnosis. Okay, what you can say, the gastric outlet obstruction, probably due to the neoplastic lesion or malignant lesion in the outlet, or by considering these factors. Okay, sir, straightforward you cannot say the carcinoma stomach, because though it depends on the mentality of the examiner, but straightforward you cannot say. Sir, আমার মনে স্যারকে জিজ্ঞেস করেন উনি।
Thank you, Professor Masud Karim. And now I'll request Dr. Shivendra, you can ask question to our students.
Only thing is he has made a diagnosis of gastric outlet obstruction. 2-3 things where there was no visible peristalsis he has mentioned, and there was a bilious vomiting. So usually in gastric outlet it should be non-bilious vomiting or vomiting of stale food. He has not mentioned on those stale food, though he has discussed now. And suction or splash he should have examined and mentioned in this examination.
Right. Okay then. So what next? Dr. Mujahid, what will you do now?
I
So
will go for
I'll back to
Abergen.
Professor Bhargav's questions. So an endoscopy. Okay. So this is your endoscopy report. Can you read it? Just briefly, I've highlighted the area. The stomach, the body, and the antrum showed a huge ulcer-proliferative lesion, biopsy taken, and the endoscopist clinical diagnosis. Endoscopist diagnosis is the carcinoma of the stomach.
Yes, sir.
What are the other things endoscopist should mention in his report? Dr. Shivendra, will you please give us some ideas to the students what he should expect from the endoscopist? Shivendra, can you hear me?
Yeah, sorry, I just muted it. So I think he should mention the characteristic of the lesion, whether it is ulcerated lesion or it is a proliferative growth is there, exact site of location, whether it is in the antrum of pylorus or it is the proximal stomach, whether a scope is passable through the pylorus or not. Those all things should be mentioned. And also he should mention the distensibility of the stomach. Many times if there is diffuse type, there is only the finding will be the loss of distensibility of the. So these things he should mention.
Right. Right.
So
Thank you.
also the curvature, in which curvature?
Yeah, which
Lesser?
curvature also, yeah. Location that he should mention, the lesser curvature or greater curvature that he should mention. Distance from the G junction is also important if you are planning. Any lesion is in the proximal body or something, then it should be distance from the G junction also should be mentioned.
Okay then. Thank you. So the histopathology report reveals as a section shows the features of poorly differentiated adenocarcinoma with ulceration of the surface. Are you happy with the report?
No, sir.
Okay, I think details about the report.
No, কেন বলো কি দেখতে চাও?
কি দেখতে চাও? What do you want to say more?
Sir, poorly differentiated bad prognosis. That's why I say.
No. What are the other findings, microscopic findings you want to know from histopathologist, or you are happy with this just one-line report? Section shows a poor.
Cytological neoplastic cell or any other cell type.
I think that will be a very long discussion. There is a reporting pro forma, I think. A reporting format is there. Dr. Shivendra, will you make comment on this report?
I think they have not mentioned the description, what is the characteristic of nature, whether some cells are there of signature cell. Those things have not been mentioned. And the poor signature cells have a mucus inside the cells, such that those descriptions are not there. Or if purely differentiated, then many times it is better to do immunohistochemistry to confirm which type of poorly differentiated it is. Though they have clearly mentioned the adenocarcinoma, that showed that they are confident that it is a mucinous tumor or adenocarcinoma, but if most of the time poorly differentiated tumor, it is very different to differentiate whether it is adenocarcinoma, squamous cell carcinoma, or even a lymphoma. So many times you need to do an immunohistochemistry to diagnose it.
to settle the issue. Yes, right. Okay, then what next? Mujahid, what is your next?
Where I will do some staging investigation, upper abdominal CT scan to see the tumor size and lymph node status and lesional involvement and
What to
pancreatic.
do? Scan.
Sorry, sir.
What do you want to do?
I want to do some staging investigation.
What is that?
CT scan of abdomen and chest X-ray, preferably CT scan of the chest.
Okay, chest and abdomen. Okay, I have these investigations. Can you see these investigations?
Yes, sir.
What is this? At this stage,
This is liver subcutaneous liver.
another side,
Stomach, fundus of the stomach.
then can you see it clearly?
Then, yes, sir, I see clearly there is a lesion involving the laser curvature and almost a whole thickness of the laser curvature. And greater curvature is normal. Greater curvature over is normal.
No.
There is hypodense shadow in the pancreatic region, peripancreatic.
What is the relationship with the pancreas?
Fat print between the pancreas and the stomach is maintained.
Okay. Dr. Shivendra, what are the things a student should know from the CT scan, and what particular point you will see, or you will tell during your presentation or now? Dr. Shivendra, can you hear me?
Just a minute. I think he should report whether there is any metastatic disease in the form of ascites, free fluid, liver mets are there or not, and then later on come out to assess the local resectability. And the location of the tumor, it is entropyloric lesion, it can see, and whether it is maintained, fat planes with the pancreas are maintained or not. Though the sensitivity and specificity of CT scan to detect pancreatic involvement is less than 60%. So it is not a very good investigation to diagnose whether pancreas is involved or not, but it gives an idea whether pancreas could be involved or not. Second thing are the nodes. Nodes, we have to look for whether there are the para-aortic nodes are there, celiac or not, because that makes it a fourth stage disease. If only perigastric nodes are there, that makes it stage 3. Those are important if you are planning to select group of patients for neoadjuvant chemotherapy. But first aim is to assess the rule of metastatic disease, then come to assess the local resectability, and that is the plan to assess the CT scan.
Okay, then. Thank you. Thank you. And report of this patient as stomach. Staging is T2N0 M0-MX, and diagnosed a case of the carcinoma of the body and the pyloric part of the stomach, T2N0. What you want to do? Mujahid.
Yes, I will do some investigation to see the nutritional status and fitness of this patient and arrange a tumor board for next plan.
What would be the plan? So all are here. The board member are here, and they have seen the patient, they have seen the reports, and you are discussing with the member of the board. And what do you think? What decision will take the MDT with this patient?
Before we doing any definitive procedure, we can do staging laparoscopy.
Dr. Shivendra, what would be the approach? At
I
this
think I doubt this report because this is mentioned T2 and 0. But if you go to see the CT scan, it appears it is full thickness involvement. It will be at least T3 stage, in my opinion. So though the notes are not very appreciable,
yes.
but if you see in the enteropolyp region, it appears full thickness of involvement. So it should be at least T3 disease. That is my impression.
This one, I think.
Yeah, this one it appears with full thickness involvement is appears to be.
Okay, right.
So my impression will be a T3 disease at least. And there is evidence of partial obstruction also.
Right. Right.
And also the CT chest has not been done. That should be done. If at least CT chest must be done.
Yeah. CT chest is NAD. Nothing about
Is it a diffuse type or intestinal type?
It doesn't appear to be diffuse. It is mostly located
Mostly
in
diffuse type.
Okay. Then what should be the next appropriate step for this patient?
In my opinion, we'll be planning if it is because it is partially obstructed. The two approaches are because it is symptomatic, so you can go ahead with surgery first. Other option, if it is partially obstructed and we are able to do a nasojejunal intubation at least, so that we can feed, then we'll plan for neoadjuvant chemotherapy after doing staging laparoscopy. That will be our approach.
So first there will be there should be a staging laparoscopy.
Yeah, always staging laparoscopy should be done first.
What about the approach I will adapt, whether it be a surgery or be a neoadjuvant therapy?
That is what I told you, because our approach will be, because it appears T3, our preference will do a neoadjuvant chemotherapy. For that, we usually put a nasojejunal intubation so that we can start feeding and build up and start neoadjuvant chemotherapy.
Okay,
But
then.
practically in our setup, most of the time it is very difficult for patient to maintain a nasojejunal tube. So other option remains going upfront for surgery, do resection, and then later on give chemotherapy.
Okay. So this patient had a staging laparoscopy. Okay, this is the report of the staging laparoscopy and the findings. Dr. Shivendra already have seen it. Now, how we'll proceed now?
Because it is an extensive peritoneal disease, that PCI score is 12. So patient should be planned for palliative chemotherapy. The other thing that remains is how to palliate his symptoms. So our plan will be to do a palliative stenting followed by chemotherapy. That will be our plan.
Exactly right. So your plan is the palliative stenting that will alleviate the symptoms of obstruction, right? And then patient chemotherapy.
Yeah.
Dr. Kamal,
Yes.
এই তো right time. কেমন আছো? Shivendra with us.
Hi, Dr. Shivendra, how are you?
I am fine, Dr. Kamal.
So please say hi to our good friend, Dr. Rawal.
Yeah, good. Definitely.
Okay. So, Ajad bhai, what I can do?
So our plan actually the CT scan finding was as T2N0, but our impression CT scan is not a T2, it's rather a T3 disease with a partial obstruction, and we took decision to undergo a staging laparoscopy, and the staging laparoscopy revealed extensive peritoneal disease, and ultimately the decision has been taken as patient has got a partial obstruction, should have a stenting facilities if we have, and followed by a palliative chemotherapy.
So, that is the gold standard now. But I think in our country, the main problem is that majority of our surgeon colleagues are still in the thought process that stomach surgery is the first area is surgery. So they normally we get majority of the patient post-operative. But if you look at the history, that initially surgery followed by adjuvant treatment was the protocol. Then perioperative chemotherapy came, the magic trial. Now the perioperative flawed protocol has come. And the very recently, the recommendation of this laparoscopic evaluation, not to trust the imaging, is very important. Because if you look at the flawed trial, they had a good success because it was either T2 disease or node positive, but they confirmed that it is not metastatic. So the confirmation of metastasis, no metastasis based on only imaging is not always possible. That the case that you have discussed, that it was T2 clinically, but finally when you opened up, you found it was not. So this is a everyday problem. Another problem I want to share with the students: don't read the report of the imaging. Please try to look at the film and you try to understand, because sometimes radiologist colleagues don't know what you are looking for. For them, nodes is important. For you, the peritoneum picture is important. You see the peritoneum, you may understand that there is some problem. The small, mild diffuse ascites may not be a big issue for them, but for you, that is a big issue. So sometimes a radiologist is not oriented for CS stomach or I mean this malignant case handling. He or she may miss it. So my point is that our surgeon colleagues, students should be oriented to not to read the report only. They should start looking at the film, comparing it, going back, and then to understand. And if required, they talk with the radiologist. Are you sure about, I was looking for a specific this thing, do you have this? Then the radiologist will understand what I am looking for. Dr. Shivendra is a fortunate person because they are working in an environment where everybody understand everybody's language. But we are working in a funny area. The patient who will go to which radiologist, even I don't know, even maybe I have never seen that report of the radiologist, that will come to me, and I cannot ask for a second report for consideration of the cost. So I need to depend on that. So this is something different. What Dr. Shivendra is enjoying in his center, because they all are oriented about this type of things. So they can really communicate with each other. That is an advantage. And for us, we need to be more cautious when we are going further. Thank you.
Thank you. Professor Margushan, sir, will you make any comment on this patient? Or will switch over to Dr. Shivendra's presentations? And then we'll take
What Professor Shivendra has said is fine. But actually, the problem is that the stenting for stomach cases is very minimum in Dhaka at least. I have done only 2 or 3 for them for stomach stenting. One for a benign disease and one for malignant disease. And not many people are doing it because they cannot collect the stent there. They are ready to put, but they don't have it. But if you have a stent, actually, my question is to you whether this 9 centimeter lesion is suitable for stenting. The long lesion, say 9 centimeter from the pylorus. So you see the report of that report, that the CT scan report.
Can I comment?
Yeah.
The thickening about for 9 centimeter.
I think stenting can be done, but in our setup, if the availability and cost are issue, then the other option will put a nasojejunal tube so that we can feed, and meanwhile we can start with chemotherapy. Many times once we start chemotherapy, tumor responds, and it gradually the passage opens up and patient starts tolerating liquids and soft diet. Issue is we're jumping up at the surgery, sometimes always delay the chemotherapy, and many times these patients have delayed gastric emptying and the chemotherapy is delayed by months or weeks. So that is our priority for these states, to start chemotherapy as early as possible.
Yeah, that is always preferable because this law, is not a suitable case for a surgery.
If stent is not there, then the nasojejunal tube will be other option which can be put, and we can start chemotherapy by next few days only.
Right. And how can you keep the nasojejunal tube?
The patient have tolerated even up to 4 cycles in our setup. We have given a float and patient has been there, and many patients improve by second cycle and their tubes are also out.
Taken out.
Yeah, taken out. So
that is a good option then.
Then the nasojejunal is also very good, reasonable option.
Okay then. Thank you.
Right. Thank you.
Thank you. Dr. Kaulsi bolbe?
Adit bhai, I have one small comment to add. We have seen many patients, they are operated and found it was not fit for surgery, then a bypass surgery is done. So I will request the colleagues not to go for that, because Dr. Shivendra was telling that first of all, doing a laparotomy, you are delaying the definitive treatment, whether even in the palliative, also you cannot give it. And number 2, every patient should not be a candidate for a bypass surgery. Bypass is required when there is a definite obstruction. And I talked with many surgeons, they said, there is no obstruction, but there will be obstruction. So for that reason, when I went there, I did a bypass. So this is a discussion I heard, and I think it is not just justified. So it is a message that even, say, for example, we opened it and realized it is not an operable case, so we should not do a bypass. I need a comment from the surgeon colleagues on this point.
Okay, thank you.
Well, that was the teaching beforehand. even for pancreatic cancers, we have to do 3 bypasses because we had no stent like that for the pylorus. Now, as the stent is available, not in Dhaka, maybe not in Dhaka, but where there somewhere they can go and they can do it. They can go to Calcutta and do it. Why do you go for a surgery?
Exactly.
Where you can have a fistula, very definitive chance of getting a fistula.
Okay,
so
thank you, sir.
you come back from that side, that you do the minimum. And when the stent is available, you put a stent there. That is the best way.
Thank you, sir. Thank you. Now, Dr. Shivendra, time is yours. You please share your screen. I have posted you. Please share your screen and present, please.
Just start.
Then we'll take the question from the students. chat box যেগুলো আছে will give answer your questions.
Are you able to see my screen?
Yes, yes.
Yes.
So, good evening, everybody. As you know, the cancer in stomach is a leading cause of cancer-related death after lung carcinoma. The incidence has been decreasing in the West due to changes in diet and other environmental factors, but the decrease is mainly limited to non-cardiac gastric cancer. The incidence of proximal gastric cancer is increasing, and also the prognosis of stomach cancer remains poor, except in the East countries like Japan or East Asia, where because of screening protocol, the prognosis has improved because they are able to pick up disease very early. So how to evaluate these patients of carcinoma stomach? Usually they present with mainly non-specific symptoms like weight loss, anorexia, pain in epigastrium, or occult GI bleed in around 20% of patients. Usual presentation of weight loss and abdominal pain. Early satiety could be another symptom, especially for diffusely infiltrated tumor like signet ring cell carcinoma. Always, once you examine, always look for the ascites, palpable mass, presence of a left supraclavicular lymph node, Bloomer cells on the parietal node, or even an iris node. Iris node is a left axillary lymph node which is seen in the proximal gastric cancer malignancies if they are spread. Also, on ultrasound, you can find a Krukenberg tumor. So usually the diagnosis is based on the upper GI endoscopy. And upper GI endoscopy, if you are a very obvious growth is there, one should take a biopsy. And always multiple biopsies, at least 5 to 8 biopsies should be done from all 4 coordinates of the lesion. As you increase the number of biopsies, the sensitivity increases up to 98% if the biopsies are increased to 7 to 8%. If you see that the gastric mucosa appears completely normal and there is a decreased distensibility, then it could be a linitis plastica. In these cases, one should take a biopsy on biopsy, that is a deeper biopsy, so that get a deeper tissue, because in these patients, there is usually submucosal infiltration is more as compared to the mucosal involvement. Also, doing a narrow band imaging, which is usually available in now the recent endoscopes, this is also gives such area of suspicious area you can identify and then do a biopsies. Other things are chromoendoscopy or confocal laser endomicroscopy. The confocal is not available in most of the centers, but chromoendoscopy can still be easily be done. But the main at present is narrow band imaging. If there is some doubtful lesion or ulcerated lesion is there, you can do a narrow band imaging or endoscope. So this is you can see this is a only indistinct gastric lesion is seen, which on narrow band imaging or indigo carbene chromoendoscopy it appears ulcerated lesion, and you can take a biopsy from this. If you see the endoscopy, you will not be able to appreciate this lesion. So this appears to be a small early gastric cancer. If there is some doubt is there, sometimes in the deeper biopsy is required, you can do an endoscopic ultrasound also and then take a biopsy from the wall by doing an endoscopic ultrasound guided biopsy. This is also very helpful, especially in the diffuse type of cancer or a signet ring carcinoma. And it also helps in the staging of the tumor because you can identify T1 or T2 lesions and which differentiate from the T3 and T4. But problem is usually differentiating between T2 to T3 is sometimes difficult. But you can early diagnose easily whether it is early gastric cancer or advanced T3 or T4 tumors, and it has a sensitivity of differentiating from T1 to T2 is around 86 to 90%. Also, the end staging also you can do, which has a sensitivity around 55 to 66%. These are endoscopic ultrasound. You can see the mucosa appears to be white, then the musculus mucosa appears black. This is musculus mucosa. Then again submucosa appears white, and the musculus propria again appears black on this endoscopic ultrasound. This you can see there as you move. This is mucosa, then the musculus mucosa, submucosa, then again the black is musculus propria, and beyond that is serosa. So this is very useful test to differentiate the for the staging of the T stage of the tumor. It is very important. Other thing that is usually we usually do is a CT scan. it should be done in all patients of gastric cancer for proper staging of the disease, especially to rule out metastatic disease as well as to find the local resectability. But it is not a good test for ruling out peritoneal metastasis, and that is why the staging laparoscopy is important in all these patients. And it has a sensitivity of lymph nodes is less if the lymph nodes are less than 8 mm. Then what is the role of PET scan? If the PET scan is available, then the PET scan should be done in all patients to rule out metastatic disease, but still it is not a replacement for staging laparoscopy. If the FDG PET is not available, then better is to do a CT thorax and abdomen to do the rule out the lung metastasis and the pleural disease, and then do a laparoscopy to rule out peritoneal disease. And you can see that for diffuse types of signature cell carcinoma, these are usually non-FDG avid. In these patients, use a special tracer, that is FAPI PET, is very good for ruling out metastatic disease in the signature cell carcinoma. None of the tumor markers have much value, though all can be CEA can be raised, but no tumor marker has sensitivity to be used as a diagnostic marker, or even a follow-up marker is not recommended for all these gastric cancers. So biomarker test now HER2 that I think was discussed, HER2, MRI, MSI, MMR, and PD-L1 should be done, especially in all patients if possible, especially if you are planning a locally, if patient is having locally advanced disease and you are planning a neoadjuvant therapy, then all these MSI, HER2 and PD-L1 testing should be done so that you can plan the preferable neoadjuvant treatment or preferable systemic treatment. I will not go into detail of the systemic treatment, how to select these patients. Then once you've done a workup, then you have to stage the disease. As you know, this is the AGCC's latest staging. T1 is when it is confined to the mucosa up to submucosa. If T1B is when it is submucosa. Both T1A and T1B are classified as early gastric cancer. If it is involved the musculus propria or gone beyond to serosa or adjacent organ, it becomes a locally advanced malignancy. The nodal staging is based on the number of nodes. So these are usually for pathological staging after the specimen you have taken out. But preoperative staging, you have to rule out should not be any para-aortic or intra-aortic lymph node or a celiac node, because these becomes a metastatic disease and one should start with chemotherapy first. Once you have done staging, how to define the early gastric cancer, the tumor confined to mucosa or submucosa with or without presence of lymph nodes are classified as early gastric cancer. So early gastric cancer incidence is in Western countries only 6 to 16%. In Japan, it is around 30 to 50%. In India, very rarely we see, once or twice in a year, we see early gastric cancer. Otherwise, most of our cases are locally advanced gastric cancers. The classification of early gastric cancer divided into type 1 is protruted type, that is protruted with elevated proliferative growth is there. Type 2 is superficial, is appreciable. It could be elevated, flat, or depressed. And type 3 is excavated or ulcerated lesion. And these have different prognosis. Type 1 is better as compared to type 3. So this is the classification of Japanese, but we usually rarely see these patients. So practically we don't have much of use of this classification. But if you are seeing early gastric cancer, so if it is T1A, most of the time you can do away with EMR or ESD. If it is T1B with low risk, that is less than 500 micron, well differentiated, less than 3 centimeter, then also you can do a EMR or ESD. Better will be to do an endoscopic submucosal resection than doing an endoscopic mucosal resection. But most of our setup, we don't get these early cases. So even if you find an early stage, other option remains a surgical or D1 gastrectomy is sufficient for these patients, because roughly 15% of patients of T1B have a nodal disease. So for T1B, other option remains a D1 gastrectomy. So most of the patients that we see are stage 2 or 3, and these are the patients in which role of perioperative chemotherapy comes and followed by gastrectomy. So, and these patients, before starting perioperative chemotherapy, one should always do a staging laparoscopy to rule out peritoneal disease, because if the peritoneal disease is there, then it becomes a palliative chemotherapy. Your intent of treatment changes. So coming to the gastrectomy, what are the components of that gastrectomy? These are two main components: staging laparoscopy, peritoneal lavage cytology. Then comes the omentectomy, whether we do a total or a partial, or bursectomy. I will discuss what is the role of all these things in coming slides. Gastrectomy could be subtotal or total, and the lymph nodal dissection, ideal recommendation is do a D2 lymph nodal dissection, and then come the reconstruction, whether you do a Billroth 2, Billroth 1, or Roux and Y reconstruction. So staging laparoscopy should be done because the risk of finding occult metastasis increases as the T stage increases. And in T4 patients and linitis plastica patients, up to 50% of patients will have a metastatic disease on laparoscopy. So the NCCN also recommends all the patients who are planning for surgery or neoadjuvant chemotherapy should undergo a laparoscopy with cytology, and is indicated in all patients of T1B or higher. Also, always take a peritoneal lavage cytology. It's a simple technique. Take around 200 ml normal saline and instill in the peritoneal cavity in the region of the tumor, and change the position of the tumor of the patient so that the fluid goes all around the tumor, and then suck it out and send for cytology. We always do all these patients and send it for frozen section. Even if frozen is not available, take the peritoneal lavage for cytology so that it can prognosticate. And because if the peritoneal lavage cytology is positive, it is equal to presence of peritoneal chemotherapy, and you have to treat as a stage 4 disease. So at present, all these locally advanced patients are, after the MAGIC trial, should be taken up for perioperative chemotherapy because it increases chance of arterial resection, and also there is no delay, as after surgery, most of the time there is delay in starting adjuvant chemotherapy. So the neoadjuvant chemotherapy is the standard of care, and the FLOT is the standard treatment that is recommended at present for all these patients. Coming to the surgery of CA stomach, this is the algorithm. You can see once you rule out the metastatic disease, then if it is T1 and N0, you can do a T1A patient, you can do an endoscopic submucosal resection. T1B, mostly you should do a D1 gastrectomy, or if it is node positive, then you can do a D1 plus resection. Rarely in T1B, very selected group, you can do an endoscopic submucosal resection also. For T1 or node positive, a D2 gastrectomy should be done, or all T2 or T1 beyond should undergo D2 resection. These are levels of station. I think Saiful has told. All perigastric nodes, that is station 1 to 6, are level 1 stone that constitute a D1 gastrectomy. If you are going to resect the lymph nodes along the branches of celiac, whether it is common hepatic artery, splenic, or left gastric, then it becomes a D2 lymph nodal dissection. So these are 11P, 11D, the distal. These should be taken care. I think Saiful has classified where to do what lymph nodes. Coming to the margins, at least margins should be taken for 3 centimeter for all patients with well differentiated. For signet rings, preferably to take 5 centimeter margins. So usually, practically for all antropyloric tumors, subtotal gastrectomy is sufficient, but for proximal body and fundus lesion, a total gastrectomy is the option. These are the various trials which compare total versus subtotal, and they have found that total should not be done in all patients, and subtotal could be done if the negative margin is possible. It is not linitis plastica, and you are able to achieve a 5 centimeter proximal margin or 3 to centimeter margin. Coming to the lymph nodal stations, I think the at present agency recommends at least minimum of 16 lymph nodes should be there for proper staging, but preferable is to have a more than 30 lymph nodes in the specimen for proper staging. So these are various gastrectomies. The D1 gastrectomy is lymph nodes adjacent to stomach is removed, that is station 1 to 6. D1 alpha is D1 plus, level 1, together with station 7 or 8. It is classified as D1 plus. For D2, or the D1 plus lymph nodes around the branches of celiac is taken as D2 gastrectomy. D3 is D2 plus lymph nodes along station 12 to 20, especially station 13 or 14V. 13 is the retropancreatic node and 14V is the SMV node along the inferior border of pancreas. So these are stations that Saiful has told. These are the stations that we should be taken in D2 for subtotal gastrectomy, D1 plus station 8A, 9, 11P, and 12A. You need not to dissect 11D or station 10 nodes, which are important for total gastrectomy. For total gastrectomy, you have to remove 11D as well as 12. Station 10 is important, not in all total gastrectomy you need to remove, but if the tumor is located in the proximal stomach along the greater curvature, then one should do a station 10 lymph node dissection also. These are the various trials. I will not go into detail because most of the trials, though have not conclusively shown that the D2 is superior to D1 as compared to overall survival because of various fallacies in these trials. Now, still after the Italian studies, the standard dissection is D2 because it increases the recurrence-free survival as compared to overall survival. None of the studies have shown that the overall survival improves with D2 lymph node dissection, but disease-free survival definitely improves with D2 lymph node dissection. So D3 lymph node dissection, it is not generally recommended, but if there is a bulky station 6 lymph nodes, then that is subpyramidal nodes are there which are very bulky, then one should take out the station 14V, that is the intrapancreatic superior mesenteric vein lymph nodes. These should be taken if there is a bulky station 6 lymph nodes. If the tumor is extended into D1, then the retropancreatic or station 13 lymph node should be taken out. Then it becomes a D3 lymph node dissection. So if you compare with various studies, D2 versus D3, there is no added survival advantage over standard D2. This is the systematic review. This also showed there is no added benefit of doing a periaortic lymph node dissection in addition to D2 lymph node dissection in advanced gastric cancer. Coming to the role of omentectomy, so initially the bursectomy was recommended. Bursectomy included the anterior layer of transverse mesocolon has to be taken along with the anterior capsule of the pancreas. This was a part of D2 lymph node dissection. But after this trial from JCOG trial, the Japanese trial, this has shown there is no added advantage of doing bursectomy. A simple omentectomy was sufficient because the bursectomy usually leaded to increased risk of pancreatic injury because you have to take out the capsule of the pancreas. The pancreatic fistula rate was high and there was no evidence of any survival benefit on a recurrence-free survival. Now the various studies have now come, even you need not to do a complete omentectomy, but if a simple omentectomy or a 3 centimeter omentectomy should be done, but it is controversial. So for students, it is standard, one should do a complete omentectomy, but bursectomy is not needed. So I will not confuse them whether to do a partial or a total, but the standard is do a total omentectomy, but you can avoid bursectomy. I will not go into detail of these trials. Then comes, so the Japanese guidelines also at present doesn't recommend total omentectomy in all the patients, but still we are doing a total omentectomy as a part of D2 gastrectomy in our setup, in our center, but we are starting to start a trial to do a partial versus total omentectomy. Coming to what type, whether open, lap, or robotic gastrectomy. So this, you can see this 1881 first gastrectomy was done, and the gradually things have evolved. In 1992, first laparoscopic gastrectomy was done. In 2002, first robot-assisted gastrectomy was done. And now these are various trials which compare laparoscopy versus robotic. So I will show the video in the end. So if you compare robotic versus laparoscopy, there is no difference between these, whether do a robotic or laparoscopic, the outcome is same. The blood loss is same, operating time is also slightly prolonged in the robotic gastrectomies. So this is the meta-analysis. There's no difference between lab or robotic. So these are various trials which are ongoing, which might be help in deciding whether the lab or robotic is better. Coming to role of CS stomach with peritoneal mets. So up to 40% of gastric cancer patients present with peritoneal mets, whether it can be synchronous or metachronous. At least 43% of patients present with synchronous peritoneal metastasis. And if you do with systemic chemotherapy alone, the median survival around 3 to 7 months. Even with the latest chemo and targeted therapy, median overall survival in these group of patients is 8 to 13 months. So practically only 1 year survival we expect in this patient with peritoneal mets. The most common site of recurrence also after gastrectomy is peritoneum. So the metachronous peritoneal mets is also very common in stomach patients. So where is the role of gastrectomy or HIPEC comes in the CS stomach? So there are three scenarios: obvious peritoneal carcinomatosis, only ascitic fluid cytology or peritoneal lavage cytology patients, or as an adjuvant treatment resectable but locally advanced T3, T4 gastric cancers. So I will come to HIPEC and diagnose peritoneal metastasis. These are the various non-randomized trials which have shown. This is a French trial which showed that the 5-year survival also you can achieve up to 13% with HIPEC in patients. This is Japanese study. They have also done 5-year survival of around 7% and median survival up to 11 months with HIPEC. And these are non-randomized trials. This is the famous French trial which showed that the overall 1 year, 3 year, and 5 year survival was 43%, 18%, and 13% after HIPEC. But important thing was this: only benefit was there if you can achieve a CC0 or CC1. Then the median survival was 21 months. If you are not able to reach a complete cytoreduction, then the survival is only 6 months. The aim should be you should be able to all the visible macroscopic disease, then only it is going to benefit. Also, you can see the PCI, as the PCI increases, the benefit of HIPEC decreases. So no role of HIPEC even if CC1 and PCI is higher. These are the randomized trials. This is the Japanese trial as well as the Yang trial from Chinese study. They have shown that the survival also improves after HIPEC as compared to CRS alone. It was 11 months versus 6.5 months. This is the GIMSA trial from German center. The median overall survival was 11 months with HIPEC as compared to 4 months with systemic chemotherapy alone. This is another trial from Japanese center. In this also, they have shown the median survival can be increased up to 42 months in cytology positive patients as compared, and peritoneal mets also a 41 months median survival you can achieve by doing the HIPEC. Coming to role and adjuvant is if it's the bulky T3 or T4 tumors, these patients also can be planned for adjuvant HIPEC, that is doing a HIPEC at the time of doing a D2 gastrectomy. These group are T3 to T4 patients, cytology positive with no obvious mets. These patients could be taken up for adjuvant HIPEC group. The rationale is once the serosa is involved, there is always possibility of microscopic shedding in the peritoneal cavity. So the large volume of lavage washes these free intraperitoneal cells, and also systemic effect of hypothermia and chemotherapy kills these cells. So these are the various non-randomized trials. They have shown you can achieve a 3-year survival of 68% in these group patients with adjuvant HIPEC. These are randomized trials. Here also you can see the overall survival you can increase up to 62% with surgery as compared to 60% with surgery alone. So 3-year and 5-year survival is better with HIPEC in bulky T3 and T4 disease. So the prognostic impact of CRS and HIPEC in these patients, this is the meta-analysis. This also shows both as a treatment of peritoneal metastasis as well as prophylaxis. Both have shown that HIPEC has a definite role in these group of patients of peritoneal disease as a prophylaxis in T3 or T4 tumors, as well as in treatment with whether it is synchronous or metachronous peritoneal disease. This is the forest plot in which you can see all these, whether it's true of 1 year, 2 year, or 5-year overall survival, most of things favors HIPEC as compared to without HIPEC. So at present, CRS HIPEC can be done with curative intent with limited peritoneal disease if you are able to achieve CC0 or 1, or adjuvant treatment with bulky tumors in absence of macroscopic peritoneal disease. So though ESMO recommends CRS HIPEC in selected group of patients, the NCCN recommends only palliative chemotherapy at present and HIPEC only in the trial settings. Coming to role of surgery in palliation in CS stomach. So role of palliative gastrectomy and palliative GG has come down with the availability of the endoscopic stenting. So this study, they have shown that the palliative gastrectomy has no role and there is no survival benefit. It is better to do a stenting as compared to palliative gastrectomy or gastrojejunostomy. Is there any role of PIPEC? PIPEC is prescribed intraperitoneal aerosol chemotherapy, which was first performed in 2011 by Professor Mark Raymond. It is a minimal invasive but palliative procedure. In this, a chemotherapy drug is nebulized with CO2 to create an aerosol, and it consists of two phases: liquid phase, which is droplets, and a gaseous phase. And it benefits are it creates the intraperitoneal administration of the chemotherapy, and the prescribed vaporization increases the penetration into the peritoneal cavity, and it is a minimal invasive, so it is a day care procedure. So it can be done with the isolated peritoneal disease, which are persistent or progressive after more than 2 lines of chemotherapy, and these patients can be considered for PIPEC. But after discussion in multidisciplinary tumor board, so it can help in controlling the chemotherapy-resistant ascites and patients of peritoneal metastasis which are not eligible for CRS and HIPEC. So these are absolute and contraindications, which includes bowel obstruction, if there is anaphylactic reaction to chemotherapy drugs, relative contraindication as portal vein thrombosis if there is problem in access. These are relative contraindications. Always the pneumoperitoneum here is created by open techniques, and always use a balloon trocar so that there is no chemotherapy spillage into the operation theatre environment. So ascites are always separated and sent for cytology. Always do PCR score. Always do 4-quadrant biopsy for peritoneal disease every time you are doing a peritoneal PIPEC so that you can document the response to chemotherapy. And this is the chemotherapy that you always give for 30 minutes under standard laparoscopic pressure of 12 millimeter Hg. And it should be repeated at least 3 times at 4 to 6 weeks of interval. This is how it works. This is a pressurized injector. This is a capno pen which makes the chemotherapy drugs in the aerosol form and is given inside the peritoneal cavity. Because of high pressure, this aerosol chemotherapy penetrates the peritoneal layer, and it helps in controlling the peritoneal disease. This is a capno pen which is used for aerosolizing the chemotherapy drugs. This is how it looks like. You do at least 2 to 3 ports. Always use a balloon trocars, and this is the second session. You can see the biopsy is there, and always do a biopsy again to document whether the tumor is responding or not. And you have to be outside the theater when the PIPEC is going on. So this is how we plan. After every 2 cycles of chemotherapy, give a PIPEC so that at least 3 to 4 sessions of PIPEC is given, and then see the response. So complications, this is very safe procedure with only 3% complication rate, with no mortality and no major side effects. So it gives a hope in this group of patients in which the HIPEC is not possible and the patient is also not responding to 2 lines of chemotherapy. So it showed a PIPEC improves or complete relief in around 64% of patients, and few of the patients might be eligible for CRS and HIPEC if there's a good response. So there's only limited time window for doing PIPEC. So usually one should offer after 2 lines of chemotherapy have failed, one should add a PIPEC in addition to systemic chemotherapy. So I'll play the video if you want later on, or should I play? This is a video of robotic gastrectomy. So this is how it starts. This is just lifting the lever. Now the lesser sac is being opened. We have taken a laparoscopic cytology before, that is not shown in here in this. After the lesser gastrohepatic omentum is opened, the carbon dioxide goes into the lesser sac, then it is very easy to do a omentectomy. Then the planes are very well defined. So then you start a omentectomy. Usually we use a harmonic for omentectomy purpose because it is very good for hemostasis. Usually we start from the right side and then go to the for the splenic hilum area, for the left gastric vessels. So you can see the all omentum is being taken care, and the left gastric vessels are taken after clipping. So whole of the omentum is removed. And the greater curvature is cleared. Then start the lymph nodal dissection of the station 6, that is infrapyloric lymph nodes. So now we are approaching to the station 6. Part of omentum was left, which is being completed. This is station 6 lymph node. This is being dissected. This you can see that this is the pancreas, and this is the antropyloric duodenal region is coming. Here is the pancreas. Now all this tissue has to be taken. The station 14 is somewhere here. If those bulky nodes are there, then this you have to take. So now you can see we are taking all this mesocolon is brought down, all the lymph nodes. Always take the gastroepiploic vein inferiorly, just at the inferior border of pancreas. This is left gastroepiploic vein is being clipped and divided. Now take all this tissue, nodal tissue, and then comes the artery. This is right gastroepiploic artery will be coming. Then again it is clipped and divided. So this is duodenum, you can see this is being lifted, and pylorus is here somewhere. So you have to divide at least 2 to 2.5 centimeters beyond the pylorus. If it is extending into duodenum, then you have to get a bigger margin. This is the right gastric vessels is being divided. Now we are starting a nodal dissection, which is a CHL lymph node. You have to press down the pancreas. All this tissue, the node is to be taken. Now you can see this is the common hepatic artery is being visualized. Then we loop the common hepatic artery. This you can see. Now we are extending, going towards the left gastric and the celiac area. This is left gastric vein which is being clipped. Now we are starting that station 12 lymph nodal dissection. This is the gastroduodenal artery which is being seen. All these structures should be bared. All these lymph nodes should be taken. So this you can see this is common hepatic artery, this is gastroduodenal, and this is hepatic artery proper. And now this lymph node, you can see the portal vein was visible. This is 12-way node is being dissected. This is now doing the left gastric artery. All the lymph nodes are to be taken. In this patient, there is accessory left from left gastric. You can see here. So we'll divide the left gastric here after the branch from the accessory left. So left gastric is taken beyond the origin of the left hepatic artery from the left gastric. After this, you have to do the station 11P. That is proximal splenic lymph nodes. For this, again, you have to press this pancreas. You see all nodes which is taken from the superior border of pancreas. This you can see, this is the splenic artery. This is celiac, and this is completely been taken all the tissue from the.
Is this a total gastrectomy or partial?
It is subtotal gastrectomy.
Okay.
So this will be sufficient. It is not a total gastrectomy. Now we are dividing the stomach. You can see this is the pylorus. So we have taken a good stomach part of the duodenum. Now the proximal division will be done. All the lesser curve, whole of the lesser curve is taken with the specimen. The whole of the lesser curve is being taken with the stomach specimen. So only this part of the stomach is there, a part of, and then it will be done with anastomosis with the rule of Jasmine. So stated to conclude, is a steady lab plus peritoneal lavage cytology is must for surgery, before surgery and neoadjuvant chemotherapy. D2 gastrectomy is standard of care. Bursectomy is not needed. Total mammectomy is sufficient. Open lap or robotic gastrectomy all have similar oncological outcomes. In patients with peritoneal disease, CRS and hyper gives better survival than systemic chemotherapy alone, but in a very selected group of patients with limited peritoneal disease. Strong evidence in favor of HIPAC and adjuvant or prophylactic HIPAC in high-risk gastric cancer is there after radical surgery. The PIPAC shows promising results as palliative treatment but needs more trials. So this is the algorithm that we showed you. This is important for all PG students. Thank you. I'll be happy to
Thank you.
take questions.
Thank you very much, Dr. Shivendra, for your very brilliant presentation, beautiful, concise, and focused. Really, I appreciate it. I think a lot of information the students have gained from you. So thank you very much. Thank you again.
My pleasure, sir.
Yes. Now I think, yeah, our students have many questions to you. So now question answer session.
Yeah.
Dr. Hasan, please moderate this question answer session.
Yes, sir. Thank you, sir. First question was, what will be the clinical diagnosis in this case that we discussed? Preferable clinical diagnosis টা কি হওয়া উচিত? What should be the preferable clinical diagnosis? In the exam.
Sir. Bhargav sir.
উনি আছে এতক্ষণে
Sorry. I think Dr. Mujahid mixes the symptoms of this stomachs. To some extent, he highlighted the vomitings, and clinically no features of obstructions. So probably patient may have some features of the gastritis and that leads to vomiting, but no obstruction is there from the clinical finding. But it is clear that because the vomiting is the bilious vomiting, it is bitter in taste, uh, and the endoscopy, the report that we have seen, no residual food material. So it's not a case of the gastric outlet obstruction. So very short period of the symptoms, weight loss alone with these features. Uh, the clinical diagnosis would be, I think, if we say, uh, Professor Bhargav sir, your opinion, কি বলবেন স্যার?
It would be better to say obstruction, gastric outlet obstruction. Before endoscopy,
Before endoscopy,
before
exactly.
endoscopy, it is a gastric outlet obstruction. Well, in the endoscopy, actually, they have got a tumor there, but may not get it. This is actually a linatus plastica has some like features is there.
Yes. Yes.
You don't get that. So actually, jumping to clinical diagnosis like that is not welcome anywhere. You say gastric obstruction, maybe retropylotic stenosis, not completely obstruction that, maybe gastritis, and because he has got loss of weight, along with that he has got anorexia, that favors the diagnosis of carcinoma stomach.
That part examiner will come later, definitely.
Yes. That anorexia, but weight loss can occur in gastritis. Weight loss can occur in gastric outlet obstruction, and as Professor Shivendra has here, that he had bilious vomiting, so it is not complete obstruction.
Okay, so better to say a gastric outlet obstruction, but after clinical evaluations.
But it may be due to obstruction at the duodenum, due to a pancreatic growth, due to a duodenal growth or duodenal flexure, I mean lymphoma or the other extramural growth. That can come with the duodenum and cause vomiting, which is bilious.
Right, sir. The problem is that Dr. Mujahid highlighted the vomiting too much, and in his diagnosis, straightway carcinoma of the stomach. This is a but
That is what. If you don't get a lump, you cannot go straightway to carcinoma stomach. Even if you get a lump, it is better to wait for some time.
Wait for some time for the examiner to ask question.
Yes.
Right, sir. Dr. Hassan, next question.
Next question was how palliative stenting is done.
So you could go through the endoscope and put it there, just like a esophageal stenting. You go to there and do the stenting.
Okay.
Is it possible? Is it possible to do palliative stenting in case of linitis plastica?
Dr. Shivendra.
Yeah, I think it is possible, but the success rate might not be good because the contractility of the stomach is also lost in these linitis plastica tumors. You can relieve the obstruction, but the vomiting might persist because of gastroparesis.
That is
the problem with the linitis plastica.
Some sort of physiological obstruction there.
Yeah, you can relieve the obstruction, but symptoms might still be persist for quite some time.
Okay.
Yes.
Awesome.
Another question is sometimes patients with symptoms of carcinoma stomach, but endoscopy reveals normal. What can we do then?
I think if you are seeing the endoscopy, the distensibility is less. The endoscopy will get a feel once we inflate whether the distensibility is there or not. If we find that the distensibility is less, it appears it could be a submucosal disease. Then you can use a narrow band imaging. This is available in all these endoscopes. Then you can identify the suspicious area, Or if you don't have facility, then take a biopsy on biopsy, which get a deeper biopsy, so that you can get a submucosal tissue also, and that will cleanse the diagnosis.
Okay, thank you. Hasan.
Should you take the biopsy from near the pylorus or away from the pylorus?
Most of the time, these are in the biopsies in the body region, the lanitus. Wherever you suspect, you should take the biopsy. If there is no suspicious, then body is the most common area where you should find.
Yes.
Okay, Hasan.
In stenting, how can stent stay in place? Would it not propel forwards?
The stent has a flange. It is an uncovered stent. It can, because of the tumor, it will be remain in place, and with time it will be involved with the tumor in growth. So it doesn't usually move unless there is a lanitus plastica and there is no tumor at the gastric outlet area. The stent will not migrate. So you have to choose your size properly so that it just instantly fits at the pylorus area.
Okay. Another question, it is already discussed in the presentation of Dr. Shivendra Singh. What will be the distal resection margin? He already mentioned it should be 2 to 2.5 centimeter from the pylorus.
Yeah.
Okay. Antral growth and pyloric growth, how will you differentiate clinically?
Why you need to differentiate between antral or pyloric? The treatment remains the same.
Yes.
Hasan, I have a question. So what is the, Sir Shivendra sir, what is the route of transmission of metastasis to the left axillary lymph node? How it goes?
Usually it is through the peritoneal. The involvement of the left upper quadrant of the peritoneum. It goes drains into the left axillary nodes. We have seen recently also we have seen one patient.
Okay.
On PET scan we found left axillary lymph node, and when we do a FNAC it was positive.
So in my ward, still a patient, there is a metastatic adenocarcinoma in the left axillary node. Only single node, large, and FNAC done outside, then admitted in our unit. Adenocarcinoma metastatic, then we are working out. And we put the patient on endoscopy. Tomorrow probably will be do the endoscopy.
So treatment remains only palliative chemotherapy.
Okay.
So Sir Kamal will take care of those.
What is the result of endoscopy?
Sir?
What is the result of endoscopy?
Just advice today.
You see for it yourself?
Yes, sir. No, not tomorrow, sir. Tomorrow will be done endoscopy. Just we saw the patient today in the morning round.
You see for yourself when they are doing the endoscopy.
Sorry, it's too difficult, sir.
Yes.
Yes.
You will tell the report.
Next question is, what is meant by tumor epicenter?
Tumor epicenter is meant to where is the bulk of the tumor is there. That is taken as a tumor epicenter.
Okay. In case of advanced carcinoma of the stomach with gastric outlet obstruction, without stenting, what will be the other treatment option? এখানে স্যার কনফিউশনটা তৈরি হয়েছে যেটা প্যালিয়েটিভ গ্যাস্ট্রোজেজোনোস্টমি নিয়ে একটা কমেন্ট আসছে। তো প্যালিয়েটিভ গ্যাস্ট্রোজেনোস্টমি স্যার মনে হয় স্টুডেন্টটা বুঝতে পারে না যে প্যালিয়েটিভ গ্যাস্ট্রোজেনোস্টমি should be done in gastric outlet obstruction. When there is partial gastric outlet obstruction, then palliative gastrojejunostomy is not recommended.
Or if you can put a tube up to the jejunum.
Yes. That is recommended by Professor Kamal sir.
That is better than going for surgery.
Yes, sir. This is the message. Sir, up to this, our question next.
If the vaginal tubing is not possible, then a feeding jejunostomy?
That could be another option.
Could be another option.
If facility is not available, so even a feeding jejunostomy can be done. But if you are doing a feeding jejunostomy, then in the same time you can do a GJ also. Gastrojejunostomy will also not take much. If your facility is not available for neither stenting or nasovaginal tube then palliative GJ will be a better option than having a feeding jejunostomy, because at least patient will be able to take orally.
Yeah, the satisfaction of taking something orally.
Yeah.
Yes, that's the important thing. Yes. NCCN guideline also says that better to do it. Okay, then. Any question? Any more question?
No, sir.
Okay.
Chandok sir.
Okay, Hasan, thank you very much. As we are at the end of the session. Dr. Shivendra, thank you very much for spending
Thank you.
more than 2 hours time with us. We'll invite you again in our future webinar. And thank you very much for teaching, training, and mentoring our junior surgeons in your center.
It is my pleasure.
So thank you very much. And we hope so you will continue it to train our more surgeons from Bangladesh. And Rajiv Gandhi will extend the helping hand. And thank you very much. And just extend our thanks to uh, Professor Sudhir Rawal and
Yeah,
express our thanks and gratitudes.
yeah.
And Dr. Shivendra, just make a comment about our webinar and advice to students. Please.
I think it is a very good initiative where the student can discuss as a PG student with the professors, discuss a case as well as get opinion from all other places. If you're being at a college, you can have a professor, but you can have now whole Bangladesh is participating and you can get a different opinion, and it is very interactive. That is very good part.
Thank you. Thank you, Dr. Shivendra. Mr. Masud Karim, any comment, any advice to students? মাসুদ শুনতে পাচ্ছ?
জি স্যার, শুনতে পাচ্ছি।
Any comment and advice to students? One
Sir.
advice, they very important is that they have to analyze the symptom of the patient. This is very, very important.
স্যার
Okay.
আমি এটা একটু বাংলায় বলি। যে প্রথম কথা হচ্ছে, আমি আমাদের শ্রদ্ধেয় শিবেন্দ্র স্যার, প্রফেসর মাহবুব হোসেন স্যার, কামাল ভাই, সবাইকে ধন্যবাদ জানাচ্ছি। আমরা স্যার সেই কনফারেন্স অ্যাটেন্ড করে এলাম গত সপ্তাহে। আমরা দেখি
will not understand. In English.
ওকে,
Please.
উনি আছেন না, আমি
Yes,
চলে
yes.
গেছি এই জন্য।
Yes, yes.
The last week, the conference we attended in Hyderabad, they started sharp at 7 a.m. and purely 1 hour discussion for the PG student. And I attended all the session for the student as well. At 7 a.m. to 8 a.m. was only for the PG students. And that was looks like an exam. All the senior faculties were in the dais as an examiner, and the students of the postgraduate institute, those who are postgraduate trainee, have to attend as an examinee. So they took the history, examined the patient, and they were crossed in the dais in front of all the audiences. And one of the things they added in the history is the breath holding time. That was new to me. What we usually say is the ECOG performance or Kornofsky score. But one thing they added in the breath holding time. It is usually what I studied, what is that? Then it is said it is actually indicator of the heart failure, chronic heart failure. You can assess the ability of the heart, that is especially the chronic heart failure, by holding the breath more than 30 seconds. Usually more than 30 seconds is the norm. But patient, it is recorded even 10 minutes can hold the breath without any other respiration. তাহলে এটা একটা নতুন জিনিস। And the other thing is, from the discussion of our Shivendra sir, students by this time realize so things you have to study and so things you have to know, because this is a routine practice even in our neighboring country, in an advanced center. So we are not very much far away from that time that we have to know, and our student must know all these things. Even what I saw, their student has been crossed with the all the regimes of chemotherapy, different trials, dose of the radiotherapy, even duration of the radiotherapy, short course, long course. So all the basics of this chemotherapy, radiotherapy, different regime, protocol, advantage and disadvantage have to know by our student as well. So in course of time, I think our students will learn each and everything, and they will equip with this new terminology and technology so that they can be a better surgeon than us. Thank you so much.
Okay, thank you, Professor Masud Karim. Dr. Kamal, please comment. Dr.
So
Kamal?
thank you, Ajat Bhai. It was great to listen to Shivendra. And I was trying to learn many things, but I didn't try to learn everything because I am enough being a oncologist, don't want to be a surgeon. But in the era of current medicine, we need to understand the surgeons and surgeons need to understand us. As Masood was telling, that the surgeon must know everything about oncology, but they will not practice it. And we should know everything because they are strength and weakness of a surgeon, but we should not try to practice it. Unless we don't know each other, we cannot make a team. And when Dr. Shivendra was making a presentation, he was showing the evidences of surgery, but he was also showing the evidence of the chemotherapies, the evolution of the chemotherapy. That is the essence, that it is a multidisciplinary team approach. So my request to our student colleagues, that the upcoming surgeons is that when the first, say, 20 years back, when McDonald's trial first showed 25% survival in stomach cancer, that made a huge noise in the whole world. That was McDonald's regime, very popular. It was post-operative chemoradiotherapy. But the problem was only 26% of the patient could not take treatment in the trial. Then the magic trial came and now the FLOT came. And believe me, in Bangladesh, we are practicing FLOT. Many people think that our perspective, our socioeconomic condition, nutritional status is not fit for FLOT. That is wrong. Even I gave a lady with FLOT, full dose. So it is possible. We can do it, and we are in FLOT trial. They have achieved complete pathological response. I am sure for Margub sir, he was telling about stomach cancer. Sir, this now is so good that in stomach cancer, we are getting complete pathological response. So students must know it. They should give the best. Again, I always tell, they should not spoil the opportunity. First chance is the best chance, and surgery is the best treatment for oncology. But it should be done in a proper way, in a proper essence. And I thank Shivendra for supporting us. And as Dr. Azad says, that one of your students is back to Dhaka, one is there, and we are preparing more to send to you, Dr. Shivendra. Don't worry. This will be a continuous process. That student will be going to you.
It is our pleasure if I can be, we are of any help to you.
Okay.
Yeah, so Shivendra, when you are training somebody in India, you are training person, but when you are training somebody in Bangladesh, you are helping the whole country. So here you have a bigger perspective.
Thank you, Dr. Kamal. Professor Margub sir, conclude karen sir, comment.
Well, Professor Shivendra, this was a very learning session for me. I think I have seen many things from your slides and other things. And I've taken some photograph of it actually. And this gives us hope that there is treatment for everybody with gastric cancer stomach. And I hope the endoscopist, if we could take them here, they would try to do endoscopy with much more so that we don't miss the early cancers. This chemo, that is something chromo, and this double biopsy from the same side, biopsy on biopsy. This technique should be always be done in our country. This is not the call for the time that we must practice all these things in our country, because I think in sometimes in 1995, Professor Jia went to Japan, and he has seen that they're doing this endoscopy where they're using dye to diagnose early gastric cancer, and he presented in BCPS auditorium. But nobody actually is not practicing, even now practicing it. It is now 30 years after that. So we must take up. And what I was telling to Masood, that you go and see, that should be practiced. Why you cannot go there and see it? I want to see what is my We went to do autopsy with Professor Kadri when we were in fourth year students. If you have that And I have seen my pathology professor, he came to our ward to see the patient when he could not diagnose it by looking at the microscope. So this practice of taking everybody or collaborating with everybody who will be your partners in progress, we should do it. Before teaching the students, you must practice yourself and ourselves. I will say ourselves. That will give the better result.
Yes,
And thank you again, Dr. Shivendra, Professor Shivendra. That was a very good and very elaborate lecture with many evidences there. Thank you very much.
Thank you.
Thank
I
you.
hope I will see you again very soon.
Yes,
Thank you.
yes. Most welcome, Shivendra. So thank you all. Stay safe, stay strong, stay blessed. So, okay. Good night. Assalamu alaikum.
thank you.
So when Dr. Shivendra is coming again, Adar bhai,
Shivendra, when will come to Chittagong again?
any plan to visit near future?
Whenever you'll call, I'll come. There is no.
Thank you. Thank you.
Thank you. Thank you so
Tell
much.
me, I will come.
Yeah.
Okay.
Okay, okay, see you. Thank you.
Thank you, sir.
Thank you, Azad.
Please, thank you, sir. Assalamu alaikum, sir. ভালো থাকেন।
Welcome.
দেখা হবে স্যার ইনশাআল্লাহ। আসসালামু আলাইকুম। আজকে টাইম কনস্ট্রেন্টের জন্য কাউন্টটা হলো না, নেক্সট ক্লাস হবে ইনশাআল্লাহ। জমা থাকছে এগুলো।